We go on to the next speaker. It is Jayanta Chakraborty. He's pancreatic anastomosis after Whipples PG, the other side of the argument. Jayanta Chakraborty is director of Chittaranjan National Cancer Institute, and everybody in Calcutta knows him. So, over to you.
Thank you, sir. I'm honored to present a video on pancreatic gastrostomy. Let me go through the procedure very slowly, and then we can take question and answers. So the routine, it's an open surgery where the routine, you can see the specimen is being delivered out. And the mobilization of the stomach is, pancreas is required for at least 2 centimeters, so that the chunk of the neck of the pancreas goes inside the stomach. So the posterior mental bursa here is being incised, and a suitable place in the posterior wall of the stomach is being identified to shovel in the pancreas into the stomach. So this procedure I have been doing for the last 3 years, and I think that the advantage of this procedure is that the learning curve is good, and the juniors can perform it, and it is less demanding skillfully, and the results are very good. So this is we identify a portion in the posterior wall of the stomach where an transverse incision is made around 2 to 3 centimeters. You have to see the width of the neck of the pancreas and make an incision. And then this thing what we do is that we take purse string sutures by Proline 2030. That will come to later on when I show in the end of the video, we will understand the importance of this suture. So this has been taken, and the whole thickness of the stomach is to be taken inside in the sutures. So after completion of that, anterior gastrostomy is done. So it should be rather in the body of the stomach or a bit below, and it should be around 7 to 10 centimeters in length, not more than that. It is not necessary, and it should be away from the pyloric end of the or transected end of the stomach. So this is done. And now these traction sutures are, through the anterior gastrostomy, we go through the posterior gastrostomy. The traction sutures are being held, and I usually stent the anastomosis, stent the duct so that I have a good idea about the position of the duct. And then this is the important part, is that you slowly shovel the pancreatic head into the stomach. And the mobilization part was very important initially, so that there is no untoward traction on the neck of the pancreas that can, and sometimes some branches from the splenic artery to the, or the splenic vein or the dorsal pancreatic artery can get torn. So very nicely the pancreas should be inside the stomach lumen. And because I have not tied the purse string, so I can take the bites. So what we do is that we take 6 anchoring bites. 3 posterior and 3 anterior, or dorsal ventral, whatever you say. And you can visualize the whole pancreas inside your stomach lumen. So it gives a lot of sense of security as a surgeon. And these posterior bites are first taken. The ventral bites are first taken. These are anchoring bites, you all know, with the chunk of parenchyma of the pancreas. To be honest, nothing is there much about this procedure. The only thing is that the mobilization of the head of neck of the pancreas after resection has to be done nicely, and then placing these anchoring sutures with good parenchyma of the pancreas is there. So as Sudeep had said last time, in the last video, that we in this pancreatic gastrostomy, we don't have to make much of concern about the width of the duct and the softness of the parenchyma of the pancreas, because it is not required. So first of all, what we do is that after these 3 anchoring bites are taken in the anterior part or in the dorsal part, they are then closed, sutured, and in between we take further bites. The suture here uses PDS 30. So in between the anchoring sutures, we take further bites, and then we tie the anchoring sutures. So you can say in the dorsal end of if we divide in 2 parts, anterior, posterior, or dorsal, ventral, in each segment there will be around roughly 6 sutures, 6 to 8 sutures. So 6 sutures anteriorly and 6 sutures posteriorly. That much only is required. We try to take the full thickness of the stomach as well as a good bite with the pancreas. Now you can appreciate here, while we are tying the anterior part, a big around 2 centimeter or the whole of the mobilized pancreas is inside the lumen of the stomach. And after that we come to the ventral part. And the angle sutures are being taken first. And here, before tying the anchoring sutures, we take the further bites. We should understand one thing, which is important here. The duct is usually located posteriorly. So these bites in between has to be very carefully taken so that you avoid taking a chunk of the pancreatic duct. So here a bit of care is required, and but yes, because we don't tie the anchoring sutures, we have enough space to maneuver our sutures. So this is the completed portion where we have taken sutures. After this, what we do is that we tie the bursting sutures, so that enforces the anastomosis. So it's only a 2-layer anastomosis. One is inside the lumen, and on the outside, this bursting suture is being tightened so that there will be no retraction of the stomach after the anastomosis is done. So this is a simple procedure, and the freca has been passed, and the anterior gastrostomy is being closed. So this is the procedure. The advantage, you all know that because of this, what happens is that the pancreatic juice doesn't get activated because the bile is excluded from the anastomosis. And another thing is that if there is some amount of bleeding, which can be dealt endoscopically. We have done 1 or 2 cases where there were some ulcers and it was bleeding, so it could be dealt with by endoscopy. And the other thing is that the learning curve is easier here. The resident takes only 4 or 5 cases to assist, and then they can do it independently. And the long-term follow-up of these patients, we have not come across any cases of pancreatitis or pancreatic insufficiency. I've been doing this procedure, rather 3 or 4 of our units are doing, and we have done around 40 procedures, and the results are good. Pancreatic leaks are not that much, and there is one mortality on this procedure, and that is because of Mallory West tear of the retching. And so I complete this procedure here.
Right. Thank you.
Yeah, that is it. That's it.
It's a lovely video, and you made it look so simple. Before we start, any questions from the house about PG? Yes. Yes, sir. Please. So you can take this mic.
Stop the video. Sir, 2 centimeter.
It's looking like more than
No.
nearly 2 inches.
No.
So just to clarify for the youngsters.
No.
Because if you
2 to
mobilize
2
too
point-
much, is it
no,
a...
I know that. We mobilize 2 to 2.5 centimeters. That's it.
Okay.
And only 1 or 2 venous tributaries are being clipped.
Okay.
Not much. And we have not encountered any episode of pancreatic necrosis or anything like that after this. So that is there.
Yeah, I had the same concern. In this video, although the video is beautiful, we saw that a large amount of pancreatic substance was introduced inside the stomach. Now, what happens to this large portion? Which does it undergo any necrosis or
No, sir.
ischemia or any other issue with insufficiency?
Maybe in this video it was short, because this video I had shot for the purpose of the demonstration here. And one thing I can say is that while transecting the neck of the pancreas, if there is a periampullary cancer, so we can go towards the right side so that we can get a bit of more of neck. That is what I am saying. You understand? If you transect towards the right side, you get 1 or 2, maybe 5 millimeters of extra neck, which can be useful when you are pulling the pancreas inside.
Just as a curiosity,
Yes.
if you've done endoscopy, say after
Yes,
some
we have
time,
done endoscopy, sir.
What do you have the findings of the projected pancreatic stump?
Yeah,
inside?
it is fine. The projected pancreatic stump is fine. 1 or 2 cases we have done because of the bleeding after that, hematemesis. We have found that there are some ulcers, and which could be
long term.
Long term, no. Right now,
Does the pancreas again level off with the posterior
I have not
wall of
done
the
any
stomach?
endoscopy. I can do it. Obviously, it's a
We
good
can
suggestion.
add a point here, sir. We can add a point here. Why it looks longer is posteriorly it will only be 2 centimeters, because you are retracting the stomach anteriorly. The other wall on the anterior surface looks wider. Otherwise, it is not actually wider. It's only 2 centimeters. Where it matters is posterior wall. There it's only 2 centimeters. Because we are seeing from above anterior gastrotomy,
Yes.
it looks bigger. And we have also done this. The commonest complication being bleeding. Post-op bleeding is more in these situations. We have done a lot of endoscopies. And almost it looks only 1-2 centimeters anteriorly when you go back and do the anastomosis. Otherwise, technically, the posterior to pancreas is important. Most of the times, that's only 2 centimeters.
Thank you.
Yes,
Yeah.
that is correct.
Yes, sir. Please.
Actually, it's good to mobilize as much as possible. The fear of pancreatic stump necrosis is not true. We have not seen any of them. And if you have a longer stump, actually you can even avoid anterior gastrotomy and do a fairly good pancreatic gastrostomy with the single gastrotomy. And that would reduce the amount of, the chance of bleeding and...
Thank you. Just yeah.
Yeah,
Could you please be quick?
It's been a preferred technique these days to do the PG. Only one question in mind it always comes is that how much to tighten the purse string? How much to tighten the purse string? Okay. I wouldn't use a stent earlier often, but now these days I do use stents in the duct. The thing is that I had one patient in a follow-up who came back, for a CT scan, and there was definitely dilated pancreas and atrophic pancreas, like a chronic pancreatitis, which I assume was because I probably did the purse string a little too tight. So that's the question: how much to tighten it?
That depends upon your assessment as a surgeon. I can't say anything.
Yeah, so how I've modified is I've started using a stent along with it in a hope that
We
I'll
do
be not-
stenting,
yeah.
that's why. Stent is required. That is probably the answer to what you are saying.
Now,
Thank you.
Pancreatic anastomosis is purely an individualized, experienced technique. There's no superiority of one or the other. There's no superiority of one surgeon or the other. It's all your experience, and then how many you do, what you're comfortable with, how much leak rate you have with what different procedures. That's what matters. There's no technically. Only technically we should ask you is how would you prevent post-op bleed in case when you're doing a PJ? Is there any special technique to prevent it?
No, post-op bleeding from the pancreatic
Stump, yeah. it's
stump,
more-
there is no technique for that. I don't know. So 1 or 2 cases has bled, and we did an endoscopy. We did not find any bleeding from the pancreatic surface. It was from the gastric surface. And then argon plasma coagulation, etc. was done. So that is purely endoscopic domain.
Yeah. Thank you very much, Jayanta, for a nice video.